In this unit, we will look at problems associated with the liver, the gallbladder, and the pancreas. If you think about it, the liver has one of the worst jobs in the body. It directly receives venous drainage from the stomach and the intestines. So anything we put in our body is drained and goes directly to the liver before it is released into the general circulation. As a result, the liver is under the constant threat of any drug, toxin, or microorganism that is picked up. The good thing is that the liver has two main defenses to help protect itself. One is that it has a large reserve capacity. On a day-to-day basis, we only use roughly 10% of our liver cells to meet the normal requirements. Secondly, the liver has a large regenerative capacity. It is able to repair and replace damaged cells. The problem then is that many disease processes are well advanced before enough liver tissue is destroyed to produce signs and symptoms. Much liver damage occurs before a person knows there is a problem. As a result, these diseases are usually chronic and severe. What we are going to discuss here are the consequences of liver disease. The first consequence is jaundice. Jaundice is characterized by hyperbilirubinemia. This is bilirubin levels above normal. This will result in a yellow-brown color of the skin and the sclera of the eyes, as well as the mucous membranes. This is an easily observed sign that something is wrong with the liver or the bile system. Jaundice is usually always present as a part of liver failure. There are three possible problems that can lead to jaundice. One is the excessive lysis of red blood cells that release bilirubin from the heme proteins. Second is an inability of the liver to conjugate or excrete bilirubin. Bilirubin is only toxic when it is not conjugated to another material. And the third problem is obstruction of the bile duct. We'll first look at the hemolytic form of jaundice. This is due to excessive lysis of red blood cells. This lysis of red blood cells results in the release of hemoglobin. Bilirubin is a product of hemoglobin breakdown. Bilirubin will then become conjugated to another compound to make it less toxic and more water soluble, so it can be excreted by the kidneys. There are two main causes for this form of jaundice. One is immune mechanisms that attack the membrane of the red blood cells. This may be due to an incompatible blood transfusion, where the person received the wrong blood type, or this is what happens between an Rh-negative mother and her Rh-positive fetus. Another cause is hemolytic anemia that also results in the destruction of many red blood cells. As a result, you will see an increase in bilirubin conjugation and excretion load on the liver. Initially, the liver is able to cope due to its large reserves, but the only sign you may see is darker colored urine. Eventually, the liver becomes overwhelmed and bilirubin levels increase in the blood and tissues. This bilirubin is in the unconjugated toxic form. Remember, the kidneys can only excrete the conjugated form. This poses a serious threat to newborns because their blood-brain barrier is not developed enough to prevent the toxic form from getting to the brain. This will result in a condition known as kernicterus. The second form of jaundice is hepatocellular jaundice. This is an inability of the liver to either conjugate or excrete bilirubin. This is the most common form of jaundice. Various causes. It could be due to a viral infection, such as hepatitis, tumors, therapeutic drugs, especially steroids, and toxic chemicals. These first four causes all result in damage to the hepatocytes so that they are unable to conjugate the bilirubin. Two other causes. It could be a genetic defect in conjugating enzymes, so that the person does not produce adequate enzymes. Or it could be due to a lack of enzymes in a newborn. In an infant, enzymes may not function for the first 7 to 14 days. This is known as neonatal jaundice. These last two causes both result in defects in the ability to conjugate the bilirubin. The third form of jaundice is obstructive jaundice, where there is obstruction of the bile duct. This results in cholestasis, where the draining of bile into the duodenum is reduced or stopped. As a result, bilirubin and bile salts will begin to accumulate first in the liver and then in the blood. Initially, the bilirubin is conjugated, but later you will see both types in the blood. This results in hyperbilirubinemia, where you see increased levels of both the conjugated and unconjugated form in the blood. Another trait is pruritus. This is an itching sensation in the skin due to increased bile salts in the peripheral tissues. You will also see gray-colored feces and the development of bile lakes due to the dilated bile canaliculi, which causes the bile to leak into the surrounding tissues. There are two main causes of this form of jaundice. One is intrahepatic obstruction, intra within the liver itself. This form is due to drugs or infections that damage the liver. In response, the liver will swell or undergo an inflammatory response that results in compressing the hepatic bile canaliculi and will result in a decrease in bile flow. The other form is extrahepatic, outside of the liver. This may be due to blockage of the bile duct. This could be the result of a tumor, pancreatitis, cholangitis, which is inflammation of the bile duct, a bile duct stricture, gallstones, accumulation of pus from a bacterial infection, or a congenital malformation. This is biliary atresia, where the duct is either inadequate to drain the bile from the liver, or there is not enough of the duct to do the job. This is showing the three main causes of jaundice: excessive hemolysis and what causes that, obstructed bile ducts, what causes that, injured hepatocytes and its causes. Another consequence of liver failure is malabsorption. This involves the malabsorption of fats and vitamin K. With fat malabsorption, you will see a decrease in fat emulsification and absorption. This will result in weight loss and steatorrhea, which is a high concentration of fat in the stool, which causes them to float. These are both characteristics of chronic liver failure. Vitamin K is a fat-soluble vitamin, so it stands to reason if there is a problem with absorbing fat, there will also be a problem absorbing vitamin K. Vitamin K is used to synthesize many of the plasma clotting factors. As a result, you will see abnormalities in blood coagulation. Another consequence of liver failure is disordered hepatic metabolism. The liver is responsible for metabolizing many materials in the body. This will result in weakness and weight loss, blood coagulation abnormalities due to defects in hepatic protein synthesis. Remember, many of the clotting factors are made in the liver, so this, on top of the malabsorption of vitamin K, will result in significant problems with coagulation. You will see a decrease in prothrombin and other clotting factors. You will also see hypoalbuminemia. This is a lack of the plasma albumin. Albumin is the main protein in our plasma. If its concentration decreases, this will result in a decreased blood osmotic pressure, and as a result, water will leave the blood, going into the tissues, causing peripheral edema. This will result in the pitting form of edema. You can see hepatic encephalopathy. These are neurological abnormalities related to altered protein metabolism. Now, toxic materials will begin to accumulate because the liver is no longer able to inactivate them. One example is ammonia that comes from the breakdown of amino acids. Usually ammonia is used to make urea and then be cleared from the body, but now this can no longer happen. This will result in lethargy in mild cases and disorientation and coma in more severe cases. You will see altered lipid metabolism. This results from defects in hepatic lipoprotein synthesis. Fat will begin to accumulate in the liver, resulting in a fatty liver. You can see depressed chemical and drug detoxification functions of the liver. Materials are going to be removed from the body much more slowly. As a result, one may need smaller doses of therapeutic drugs because they are not being broken down. You can also see higher levels of circulating hormones, again due to the liver's inability to inactivate them. And you can see hepatorenal syndrome due to renal failure that follows liver failure. This would be the result of an increased level of circulating vasoconstrictors that would normally be cleared by the liver. One of the main diseases of the liver is hepatitis. This is an inflammatory response in the liver due to a viral infection or due to toxic drugs. There are two forms, acute and chronic. The acute form is usually caused by viruses. Traits of the acute form: you will see very little fluid exudate formation, and lymphocytes tend to be present over macrophages. Now, remember, this is an inflammatory response. We talked about inflammation earlier. The two main signs of inflammation are large amounts of fluid exudate and macrophages being present. So these first two symptoms or traits of acute hepatitis differentiate it from the typical inflammatory response. You will also see scattered areas of necrosis and regenerating parenchymal cells. The liver will be swollen and discolored due to the bile backup. You can see the person will become weak and fatigued. You can see nausea, anorexia, fever, and jaundice. Usually has a 4 to 6 week duration, usually with a complete recovery. Massive liver necrosis is rare, but when damage is extreme, death may result. We're going to focus on viral hepatitis first. This is caused by a special group of viruses that only attack the liver. The first of these viruses is the hepatitis A virus. This causes infectious hepatitis. The traits of this disease: it is an acute form of hepatitis, relatively mild condition. It has an incubation period of 3 to 6 weeks, during which no signs or symptoms may be seen, but infection is proceeding. This form of hepatitis is spread by contact. The virus is eliminated in the urine and feces, and as a result may contaminate food and water supplies where hygiene is poor. This form of hepatitis does not result in chronic hepatitis, and there is no association with liver cancer. Also, it has a very low mortality rate. Hepatitis B virus causes serum hepatitis. This form of hepatitis is transmitted via infected blood or blood products, as well as sexual transmission. It has a 6 to 24 week incubation period. This form has a carrier state, which we will talk about in just a moment. Up to 10% of the cases of hepatitis B will result in chronic liver damage. There is an association with liver cancer, and this form has a 1 to 2% mortality rate. The hepatitis B virus is known as a Dane particle. It has a DNA core surrounded by a protein coat. The protein coat acts as the antigenic component. This is what the body recognizes as being foreign, and this is also what allows the virus to recognize and attach to the host cells. The only part of the virus that enters the hepatocytes is the DNA. The infected hepatocytes are then directed by the virus to make new viral DNA as well as protein coat pieces and assemble the virus before they are released. Through this process, some of the protein coat by itself may enter into the blood. This is referred to as the hepatitis B surface antigen. Detection of this particle in the blood is used to verify hepatitis B infection in potential blood donors. This antigen alone is not infectious. However, if it is present, then most likely the infected form is present as well. This picture shows how the virus takes over. The DNA enters and then directs the hepatocytes, the host cell, to make new DNA as well as the protein coat, assemble the virus prior to release. But again, through this process, some of these proteins alone may enter into the blood. This picture represents a viral load on the liver cells. The third virus is the hepatitis C virus. This results in 95% of post-transfusion hepatitis. Transmission of this virus is through contaminated blood. It has a 7 to 8 week incubation period and also has a carrier state. Up to 50% of the cases of hepatitis C lead to chronic liver damage. To date, there is an unknown association with liver cancer. Now, what is this carrier state? This occurs when people with hepatitis B or hepatitis C are unable to completely eliminate all of the viral particles. As a result, they act as carriers. Infection may continue in these patients, showing minimal liver damage, or they may show no signs of abnormality at all. Because they are carriers, they are able to spread the disease. This is dangerous because many people may not know they are carriers or that they even have hepatitis. Mild cases of hepatitis may be passed over as just feeling under the weather. Carrier states have been seen for hepatitis B, C, and E, but not for A. These carrier states are highest among IV drug users. 10% of all acute cases enter into a chronic phase. Most cases of chronic hepatitis are idiopathic. If a causative agent can be identified, it is usually hepatitis B. There are two forms of chronic hepatitis: chronic persistent and chronic active. The chronic persistent form is characterized by many years of limited hepatic necrosis. You see only minor symptoms, usually fatigue. There is no functional hepatic loss due to the ability of the liver to regenerate. No treatment is indicated, but these patients do pose an infection risk to others. Chronic active hepatitis can result from an infection with hepatitis B or C. The signs and symptoms are variable, and it is often confused with the chronic persistent form. However, here with the chronic active, you will also get abdominal pain, jaundice, anorexia, splenomegaly, or encephalopathy. This form has a mortality rate of up to 50%, mainly because the regenerative ability of the liver cannot keep up with the necrosis. You will see scarring of the liver and the development of cirrhosis. So this is showing with viral infection the various forms that we talked about. Now we're going to talk about chemical causes of hepatitis. Drug and chemical hepatitis. Here, the effects may be acute or chronic and will vary in intensity from either a very mild disease up to massive liver necrosis. There are no distinguishing characteristics that can differentiate drug or chemical hepatitis from the viral form, so you need a good patient history as well as blood work. Next, we're going to look at cirrhosis of the liver. Cirrhosis is the result of parenchymal loss and replacement with scarring. The cells will be replaced with fibrous tissue. This is due to chronic liver destruction that can be caused by infection, drugs, chemicals, and alcohol, or by extrahepatic bile obstruction. These end up overwhelming the liver's ability to regenerate. You will see nodules, which represent areas of regeneration, as well as fibrosis, which is scarring. Cirrhosis is actually a non-specific final point where various other pathogenic conditions converge. Signs and symptoms of cirrhosis are variable. You will see various amounts of functional loss. This includes jaundice, wasting, blood coagulation disorders, and plasma protein deficiencies. If regeneration can compensate for the necrosis, the symptoms will be minimal or absent. Eventually, continued necrosis will deplete the reserves and liver failure will result. We're going to look at some of the consequences of cirrhosis, what happens as a result of cirrhosis. One of these consequences is portal hypertension. Remember, the hepatic portal vein is the vessel that drains the intestines, stomach, pancreas, and spleen through the liver. Portal hypertension is an increase in blood pressure in this hepatic portal vein. This is due to the restricted blood flow through the liver to the inferior vena cava. This may be due to thrombosis in or compression of the inferior vena cava, the hepatic or the portal veins. But usually portal hypertension is a consequence of cirrhosis. There are two factors responsible for the liver changes that can cause this elevated portal system pressure. One is vascular compression. All these regenerating nodules and scar tissue in the liver end up compressing the sinusoids and the intrahepatic vessels. This will increase their resistance, which causes an increase in pressure. Another factor is an increased arterial loading. This is due to an increased flow of blood through the hepatic artery. This increases the volume that the sinusoids and venules must cope with, and it adds to the increasing vascular congestion. Due to this elevated blood pressure, this results in the shunting of the blood past the liver. This results in another consequence of hepatic portal hypertension, which is hepatic shunting. So portal hypertension will cause the blood from the portal system to bypass the congested liver vessels and go to the inferior vena cava by alternate routes. As a result of the blood bypassing the liver, you will get a decreased oxygen and nutrient delivery to the normal functioning hepatocytes in the liver. This will result in further decrease in function. They're not getting the oxygen and nutrients they need. Normal healthy cells will begin to die. This may end up aggravating any existing signs of a compromised liver. The shunted blood will travel via collaterals that connect the portal veins to other venous channels. One of these collaterals follows the esophagus. Problem, though, is that it has a very thin wall, and when it is subjected to this increased flow due to shunting, it can result in focal dilations known as varices. These varices will then cause the esophageal mucosa to protrude into the lumen of the esophagus, where they are then subjected to trauma every time food is swallowed, and they will also be exposed to gastric juice. This will cause erosions, rupturing, and bleeding, which can be a serious complication. Esophageal varices are a problem because they don't present any symptoms until they rupture, and then you will see hematemesis. This problem is further complicated because the damaged liver cannot maintain adequate blood coagulation response. Remember, they're not able to synthesize adequate clotting factors. So serious hemorrhaging may result. Esophageal varices have roughly a 40% mortality rate. Therapy. One can exert pressure from within the lumen by using a balloon device, inserting a balloon and then blowing it up to apply pressure and stop the bleeding. You can use a sclerosing agent to promote a fibrous response. This is usually injected directly into the site of the bleeding. And a third therapy could be surgery to reroute the blood flow through a different venous return. This usually, though, is a last resort. Another consequence or complication of portal hypertension is the development of ascites. This is fluid accumulation in the peritoneal cavity. This will result in abdominal distension, which can compromise breathing and compress the abdominal viscera. Now, where does this fluid come from? Due to the increased blood pressure in the sinusoids and capillary beds of the hepatic and splenic tissues, it forces fluid out into the surrounding spaces. Remember, too, that there is a decrease in the liver's ability to produce albumin. This causes a decrease in blood osmotic pressure, which reduces the ability of this fluid to return back into the blood. There is also a backup of blood in the splenic vessels. This causes a decreased venous return to the heart, which will then trigger sodium and water retention reflexes, which will just add to the fluid and increase the problem. Complications of ascites would be spontaneous bacterial peritonitis. Intestinal organs gain access into the peritoneal cavity, also due to this increase in blood pressure. All of this fluid in the peritoneal cavity acts as a large petri dish and breeding ground. It produces a perfect environment for the growth of these organisms. This can be a fatal consequence of ascites. Then another consequence of hypertension would be splenomegaly. This is enlargement of the spleen. This is due to the congestion and hypertension in the spleen and its inability to drain properly. With this, you will also see hypersplenism. This is where you will see an increased uptake of the formed elements being taken up and held by the spleen. This may then result in thrombocytopenia or anemia. So this is all showing the consequences of cirrhosis. One common cause of cirrhosis is alcohol abuse. This accounts for roughly half of all types of cirrhosis. 15% of alcoholics who drink at least 1 pint of hard alcohol a day will develop cirrhosis after approximately 10 years. Now, why does this happen? Alcohol is toxic, and this alcohol toxicity produces high levels of metabolites with damaging effects. Chronically detoxifying large amounts of alcohol will deplete the reserves of detoxifying enzymes in the liver. As a result, these toxins stick around longer and do damage. Other problems associated with alcoholic cirrhosis can contribute to fibrosis. Alcoholic cirrhosis can produce fatty degeneration, which can produce liver enlargement to 2 to 3 times its normal size. You can also see chronic damage followed by scarring. You get acute alcoholic hepatitis. This is due to binges that act to exaggerate the already declining functions. Once cirrhosis is established and alcohol intake is not reduced, there is an 80% chance of death in 5 years from liver failure or ruptured esophageal varices. And this is showing the schematic for alcohol ingestion and how it leads to cirrhosis. A couple of other forms. Post-necrotic cirrhosis. This follows chronic toxic or viral damage. Usually it is the result of chronic hepatitis B. And then biliary cirrhosis. There are 2 forms. The primary form is common in middle-aged females. This is due to autoimmune destruction of the intrahepatic bile ducts that then progress to cirrhosis. The secondary form is due to chronic extrahepatic obstruction. This results in the bile accumulating in the liver, resulting in inflammation, necrosis, and fibrosis. Next, we're going to look at the gallbladder. One thing to note is the gallbladder is responsible for concentrating and storing the bile. Bile is produced in the liver. The gallbladder's function is to store it and to concentrate it. As a result, while it is doing this function, it may result in the formation of gallstones, which is known as cholelithiasis. The incidence of gallstones, this is seen in roughly 15% of all adults at autopsy. An increase in age also correlates with an increase in incidence of gallstones. The highest incidence of gallstones is seen in obese females over the age of 40. There is also an increased incidence associated with high caloric diets. And there are also various genetic factors that are involved in the formation of gallstones. In order to understand how gallstones form, we must first understand normal bile. Normal bile consists of water, inorganic ions, bile salts, cholesterol, lecithin, and conjugated bilirubin. The problem is the cholesterol. The solubility of cholesterol is helped by having the bile salts and lecithin combined with it. This forms large water-soluble compounds. In abnormal bile, changes have occurred such that the lower soluble components come out of solution and precipitate, forming small crystals on the mucosal surface of the gallbladder. Over time, they enlarge to visible stones, and usually there are multiple stones, not just one. The components of gallstones, 80 to 90% of gallstones are cholesterol. There will also be calcium salts of bilirubin, as well as calcium carbonate. The development of gallstones is idiopathic, but usually it follows an imbalance in the composition of bile. For example, there may be an increased concentration of cholesterol in the bile, for example, as the result of obesity or high cholesterol diets. The development of gallstones are also followed by a decreased bile acid production or a decreased intestinal absorption. This will not allow the cholesterol to dissolve properly. This is often seen associated with those that have had an ileoresection or people with Crohn's disease. Precipitation or the formation of a gallstone also needs a site where it can be initiated. So oftentimes patients' gallbladder's mucosa is altered in some way. This creates a nidus or a foci for the start of precipitation. Once precipitation starts, it then makes it easier for the process to continue. Complications associated with gallstones. One is inflammation, which is cholecystitis. This occurs secondarily to the irritation of the mucosa. After inflammation and repair, now the bile concentrating ability may be either decreased or lost, which will lead to the necessity for surgically removing the gallbladder. This can also result in pain in the upper right quadrant. Most gallstones, though, are associated with no symptoms. You don't know you have them until you have an abdominal x-ray for something else. Stones can also cause a problem when they move into the duct system and obstruct the flow. This is a major complication. You will get sharp upper abdominal pain, which is known as biliary colic. If this is not corrected, it can result in obstructive jaundice. Also, the lack of normal bile flow will favor the movement of bacteria from the intestines into the biliary system. This can lead to inflammation in the ducts and in the gallbladder. So this is just showing the flow chart for what happens when gallstones move into the bile duct and the consequences of that. Therapy. If a duct is obstructed, you will need surgery. If surgery is a high risk, one can be given bile salts to help dissolve existing cholesterol stones and prevent new ones from forming. You can also use ultrasound to break up the stones into smaller pieces so they can be passed normally. The last organ to look at is the pancreas. Remember that the pancreas serves two functions. It is an endocrine organ and an exocrine organ. We will look at the exocrine function here and the endocrine function in a later unit. First is pancreatitis. This is an inflammatory response of the pancreas due to damage of the exocrine tissue. One form is acute pancreatitis. This can be a life-threatening situation. This is an inflammatory disorder of the pancreas associated with edema, various amounts of autodigestion, literally the pancreas digests itself, necrosis, and sometimes hemorrhage. This has various etiologies, degree of severity, and potential to become chronic. Causes of acute pancreatitis. The two most common causes are alcoholism and cholelithiasis. It could also be the result of tumors, trauma, drug or toxin damage, ischemia, or infection. Now the first three, alcoholism, cholelithiasis, and tumor, these three lead to pancreatic duct obstruction so that the enzymes cannot be released from the pancreas. The last group lead to pancreatic necrosis. But both of them lead to the release of pancreatic enzymes within the pancreas itself. Normally, these digestive enzymes are prevented from getting into the pancreatic tissue. They are released into the duodenum and only become activated once they are in the bile duct. Right, so this is showing various causes for acute pancreatitis. Pathogenesis is associated with the inappropriate activation of these digestive enzymes within the pancreas. This is what causes autodigestion of the gland. These enzymes are extremely potent. These are the ones responsible for breaking down most of the foods that we eat. They are so strong that if they are activated in the pancreas, they will digest the pancreatic tissue. Some of these enzymes include lipases. These will digest fat within the pancreas and any structures adjacent to it. You will see areas of necrotic fat, which will give the pancreas a very soapy appearance to it. Some of these enzymes may get into the bloodstream, and they will be transported to the lung, where they can cause acute respiratory distress syndrome. Damage to the pancreas can also cause an inflammatory response. Damage to the pancreas can result in vascular damage, causing hemorrhaging and cardiovascular shock. Because these enzymes are being released in the pancreas and not getting to the duodenum where they are needed, this will result in inadequate digestion, which can lead to malabsorption. So again, here's the flow chart showing what happens when these enzymes are released. Signs and symptoms include pain, usually constant pain that can vary from being moderate to severe. This pain is in the epigastrium region and radiates to the back. You see nausea and vomiting, pancreatic necrosis, hemorrhaging, vascular shock, renal failure, and acute respiratory distress syndrome. If the person survives, They will have cysts filled with necrotic debris, blood degradation products, and pancreatic enzymes throughout their pancreas. Treatment is mainly supportive care, giving pain relief, and also trying to stop this inflammatory cascade. Chronic pancreatitis is a slowly progressive destruction of the functional parenchyma of the pancreas with various amounts of inflammation and fibrosis, dilation and distortion of the pancreatic ducts. As the pancreatic tissue is destroyed, it will be replaced with scar tissue. Causes: alcoholism is a big cause, cystic fibrosis in children not associated with biliary tract disease, and protein-calorie malnutrition. The complications of the chronic form include the formation of calcified masses that will form in the pancreatic ducts and the development of diabetes mellitus. This is due to the progression of the disease and the destruction of the islet cells, which are the endocrine portion of the pancreas.